So I'm super excited to introduce our first speaker, Dr. Rachel Manber, who's a professor in the Department of Psychiatry and Behavioral Sciences here at Stanford. She is a seasoned behavioral sleep medicine clinician and researcher. Clinically, she specializes in non-drug treatments of sleep problems in adults and youth and children and infants, so across the whole life spectrum. And Dr. Manber has over 30 years of experience treating patients and conducting research to improve non-pharmacological treatments of insomnia. She's led research projects and real-life initiatives to increase patient access to CBT, cognitive behavioral therapy, for insomnia, including in VA, where her efforts have resulted in the training of over 1,000 VA providers to competently deliver CBT-I. So huge impact on the field and our veterans. Her CBT-I treatment protocol is the VA protocol and serves as the foundation for both our CBT-I Coach app and our Insomnia Coach apps, which are super popular apps. I think CBT-I Coach has been downloaded almost 1 million times. Insomnia Coach is up over 100,000 times. So Dr. Manber will present on recent news from CMS, the Center for Medicare and Medicaid Services, I think that's what that stands for, and FDA concerning digital CBT-I and the results of a resting study on a stepped care approach predicting which patients will benefit from starting treatment with a digital modality. So I will hand it over to you, Dr. Manber.
Thank you. Thank you for this kind introduction. It's been a pleasure to work with you on the development of the Insomnia Coach and CBT-I Coach. So let me share. So I wanted to give a plug to our clinical service, which is the Sleep Health and Insomnia Program, SHIP, as well as to the Center for Sleep and Circadian Sciences at Stanford that really is dedicated to interdisciplinary, cross-campus research in sleep at Stanford. So I think I'll skip the intro and just start with the exciting news about Medicare Part B services change that's proposed and is going to be finalized in mid-November and going to effect in January of 2025. And the news is that CMS is proposing 3 new G codes relevant to the digital mental health treatment for Medicare recipients. And we are hoping, of course, that once it takes an effect, many will follow suit. And the codes cover the supply of the device. What as you know, the digital therapeutic is called a device, and the initial education for onboarding and monthly treatment management. And I'll talk a little bit more about it as I talk about the other fantastic news, which is that because the covered product under CMS has to have clearance from the FDA in order to provide the coverage, the next best news is that there's a new kid on the block, and that is that there are FDA clearances now to 2 products, only one of which is alive and kicking. So in 2020, FDA provided clearance to Somryst, which used to be Shut-Eye, and it became the first and only digital therapeutics for chronic insomnia that can be done by prescription. At the time, the prescription was only through physicians, and it was owned by Per Therapeutics. In 2023, Per Therapeutics filed for Chapter 11, and it was acquired by Nox Therapeutics. Nox Therapeutic is an in-house service, so it's not kind of available outside of it, but it has its plans to revive Shut-Eye, or what became Somryst. But the biggest news is just in the last month, Sleepio, which is developed by Big Health, received FDA clearance. And the biggest piece that we are particularly happy to report is that it can be prescribed by any qualified licensed healthcare provider, including physicians, psychologists, NPs, PAs, and more. So that means that finally we have an example of a digital therapeutics that can be prescribed for mental health, that can be prescribed by mental health clinicians that have close contact with the patient and can actually support the patient as they go through the therapeutics. So as Eric said, there are enough indications that digital CBT-I works, and I'm going to skip this slide so that I have more time to speak about other things given the shortness of my presentation. So how does digital CBT-I care proceed? The provider buys codes from Big Health. Then when a patient comes in and needs the product, the code is dispensed. So the provider then prescribes it, onboards the patient into using it, and patient receives a link to enroll in the program. Then treatment begins, and the provider can support the patient as they go through the digital therapeutics. And there is a plan, and I don't think they've completely implemented, that outcome data and progress of the patient is fed into a dashboard of the clinician so that they can better support the plan is to have good integration. And so the billing codes kind of go with these three phases. So one billing code is to supply the digital device, which means you get back the money that you spent in purchasing it. The second one is for the first 20 minutes of introducing it. And then the next code is for each additional 20 minutes that you provide the management and talk with the patient about their adherence, their engagement, etc. However, there is evidence that's growing that digital CBT-I is less effective than face-to-face CBT-I. And face-to-face, that includes both telemedicine and in-office visits and group health, treatment. So there is a comparative efficacy network meta-analysis that came out, and you can see the effect sizes for individual on-site, for group delivered, for telehealth, for guided, they call it iCBTI, which is internet CBTI, or unguided internet CBTI. And you can see the diminished effect size. In this particular meta-analysis, they did not find a difference between guided and unguided, but there is evidence in other analyses that do find a much better outcome and better engagement. So more people complete the digital therapeutics under the guidance of support of the provider. So the last piece of my talk is to tell you the results of a study that I've just completed that comes at the question of, we don't have enough providers. And the digital CBT-I does not work for everyone. Some people drop out, some people don't benefit from it. So wouldn't it be nice if we could figure out how to triage people to who should start treatment for best effect with digital and who is not likely to benefit fully, and therefore maybe best to just from the get-go start with a therapist, with the idea that those who start with a digital and do not do well still will have the option to go to a therapist. So this is a very complex study that I've conducted. And here's the design of the study. We basically recruited individuals, the details to come, and we classified at the beginning of the at baseline based on a 5-item checklist to whether or not we think that yes, the patient will benefit. Yes means the patient, we predicted that the patient would benefit more from the therapist-led TCBTI than DCBTI. So basically, once we classified people, we think you'll do well with CBTI. We think you will do better if you start with a therapist. Within these buckets, we then randomized people to either receive as first step DCBTI or TCBTI. So basically, what you see in here is within the triage checklist, people were randomized to either an online-only intervention, so they get 12 months of access to the digital therapeutics, or they get to randomized to what we call a triage stepped care or a stepped care or step in here, in which case they start right away from a therapist. Those who were in the know that we suspected they will not do well with a digital CBTI, if they were randomized to stepped care, and we thought they will do well with the digital CBTI, they started with the CBTI, but if after 2 months they've not sufficiently responded, they were then randomized to either at 2 months, we have decided, not randomized, based on clinical outcome, they either continued with what was helpful for them or they switched over to see a therapist. So basically, a patient in the yes triage either received for the whole year the CBTI or for the whole year therapist. A person who was in the no checklist either received for the whole year digital or had the option of first doing the digital, and then, if it didn't work, switching over to a therapist. So you have 4 different paths according to the triage checklist. So with that complicated design, we actually had 2 outcomes. I'm going to only talk about the insomnia severity as outcome. Our second outcome was the use of prescription sleep medications, which is also very excited, but it's beyond the scope of today. And this is basically the results. So the results that I'm presenting is not, we found overall that the triage checklist, so I go back over here. Basically, overall, we found that stepped care approach over the full year was better overall than online only. So we have 2 effective strategies, and it's very difficult to find difference between 2 effective strategies, but we found one. It's not a huge effect, but it is statistically significant. But the real important question that I want to finish today my talk about is that we validated our checklist. And what does it mean to validate our checklist? In 2 ways. First, if you just hone in on the left side, those people that we thought are more difficult to treat and therefore would do better with a therapist than with the digital, those people received therapist all the way through in one arm, or online or digital all the way through. And what you can see is there was across time, the people who were in stepped care decreased their insomnia severity significantly more so than people who were in the digital within that particular group that we have identified. So that means this identification worked. And you can see the effect size for the difference in the means at each time point increasing over time. The other way that we validated the checklist is by saying, okay, if you were randomized to only receive the digital, did you do better if you were assigned initially, if you were assigned to stepped care? So you had the option to switch over. And the answer is yes. And you can see the effect size at each time point. Notice that because we have not randomized people at the 2 months, we cannot really do any inference about the value of the switch because we've not randomized. So we don't have, the design does not support it. But we can say that the overall as a strategy worked better, even in the people that we thought will do better with the digital. So having the option to switch is probably a good thing, is what we can say. So in conclusion, digital CBTI is effective. We have 2 digital CBTIs that received FDA clearance, and the FDA clearance for Sleepio includes prescription by psychologists. There are now CMS codes for introducing and supporting digital CBTI, and the resting study demonstrates that we can identify people who might be doing better from the get-go with digital CBTI. And with that, I will end and pass the baton to the next speaker.
It's so cool to hear the news that that the interventions that are developed and delivered by psychologists are actually now able to be prescribed by psychologists, which was just so ridiculous. Such cool work, Rachel. Thank you for sharing. Next, I am going to introduce Dr. Nikki Gumport. who is a clinical scholar in the Department of Psychiatry and Behavioral Sciences here at Stanford. Her research currently is funded by grants as PI research and from the Sleep Research Society Foundation and the American Academy of Sleep Medicine Foundation. And her research focuses on how to increase access to high-quality, evidence-based sleep care by training community-based providers to integrate digital CBTI into routine psychotherapy for depression and anxiety, because as we'll hear, I'm sure, there's a high comorbidity there. She also provides clinical care for sleep disorders within the Sleep Health and Insomnia program. So Dr. Gumport will present on her on integrating digital CBTI within general mental health, and we'll share preliminary focus group findings from interviews with therapists. So I will hand it over to you, Nikki.
Awesome. Thank you, Eric, for that introduction. Can everybody see my screen?
Yes.
Perfect. Okay. So thank you for having me here today. So today I'm going to present on some preliminary data I have from focus groups about the preliminary acceptability and feasibility of training clinicians to integrate digital CBTI into routine psychotherapy. So we've already briefly touched on some of these pieces, so I'll probably go through this somewhat quickly, some of this background information. But about a third of patients who enter treatment for any mental health problem also have insomnia disorder. And when these symptoms go untreated, it can really hinder the response to treatment for other mental health problems. But what's really encouraging is that insomnia can be effectively treated with CBTI, and this also has the potential to improve other mental health outcomes. But we also know that routine psychotherapy for depression and anxiety is insufficient to adequately address insomnia symptoms. The other thing that we know is that very few providers are trained in CBTI. So the vast majority of psychotherapists have no training in evidence-based insomnia therapy. So in studies of clinical psychologists, so these are national survey studies, they found that 41% of doctoral programs offer absolutely no training, no courses, no lectures, no practica in treating sleep problems, and that 95% of clinical psychologists have no training at all in behavioral sleep medicine. So it's probably unsurprising, but I hope that I'm making you all concerned that there's a huge shortage of behavioral sleep medicine providers, both in the United States and worldwide. And often where you see behavioral sleep medicine providers in the US, they tend to be clustered in like the same areas. So there are a good bunch of us in the Bay Area, but there are not that many of us in many other parts of the country. And we've also super touched on this already, but digital health interventions specifically for treating insomnia are really promising and a scalable option. We have a lot of evidence at this point that digital CBTI is effective at improving insomnia. And there's also a lot of data that using DCBTI can also improve symptoms of both depression and anxiety. And so just recently, too, the UK updated their health guidelines to recommend DCBTI above sleep medications for treating insomnia. And that's exciting. And we have these new CMS codes coming out. And Rachel also briefly started to speak to this, but we have evidence that supported apps have better outcomes than unsupported apps. So DCBTI programs that incorporate some type of human support folks often do better, although, right, I know Rachel presented that study where that's not always the case. So by better outcomes, I mean patients are more engaged with DCBTI, they're more adherent to treatment recommendations, they're more likely to complete the program as well. But we also have limited data on how best to support and who should be providing the support. So one thing that I've been spending a lot of time thinking about is that therapists, psychologists, and other therapists are very well suited to provide this type of support because we can leverage our existing therapeutic relationships and integrate DCBTI into our routine psychotherapy. And integrating DCBTI into routine psychotherapy, which I'm calling integrated DCBTI, is one potential strategy to increase access to insomnia care that, to the best of our knowledge, hasn't really been studied up to this point. And this may help address a lack of providers who are able to provide these behavioral sleep medicine interventions, given that there's such a shortage. So the goal of the study that I'm going to present today was really to start to understand the perspective of various licensed mental health care providers on the acceptability and feasibility of integrated DCBTI. So I had 3 questions. So I first wanted to know, what do general psychotherapists identify as potential benefits and concerns with using integrated DCBTI with their patients? We also wanted to know, what do general psychotherapists believe they need in order to be able to provide integrated DCBTI to their patients? And then last, we wanted to know, what do they need in order to make actually getting training in integrated DCBTI pragmatically feasible? So at the end of last year, we conducted focus groups with 52 licensed mental health care providers who we recruited from listservs, Facebook groups from therapists, word of mouth. They were primarily psychologists, but we had some social workers, marriage and family therapists, licensed professional counselors, and we had 2 psychiatrists, so psychiatry was underrepresented in this group. They all had to be licensed mental health care providers who have a clinical care model where they see patients weekly or biweekly, and they were available at one of our scheduled focus group times. So we led 6 one-hour-long focus groups, and then after the group, folks who attended had the option to complete an anonymous survey after the group, and just about everybody, 48 out of the 52, completed this anonymous survey. And so I'm going to put the results of our first day, like what are the benefits and concerns about integrated DCBTI, up here on the slide, but I'm not going to spend a ton of time on this. The benefits are really what other studies have previously identified about benefits, or benefits about treating, like benefits of apps or benefits of treating sleep alongside other mental health problems. So things that we tend to already have seen in the literature. In terms of concerns, there were concerns about what to do with patients who aren't super tech savvy or patients who don't have internet access. I do think it's worth noting that, yes, there is a portion of the population that doesn't have a ton of internet access, and about 95% of US adults do have access to smartphones now. There were also concerns about billing, which, as Rachel already highlighted, with these new proposed CMS codes, may not be as much of an issue, hopefully moving forward, assuming they get approved. Otherwise, the integration is proposed to take 5 to 10 minutes of session time and potentially can be woven into therapy as usual, kind of like just as another piece of therapy homework, and perhaps may not necessarily necessitate the use of another billing code. But what I really want to do with the rest of my time, because I know I don't have that much time to talk today, is to think about, what do therapists actually need in order to do integrated DCBTI? And so what they shared with us that they needed is, first, they wanted to know, who should they use integrated DCBTI with? So when we think about practical considerations of what we're going to train therapists in, figuring out who is an ideal patient to do this with is something that they certainly said they want to know about. They also wanted to know about what happens in CBTI, what's the content, and what's the rationale, with the really big idea of they didn't want to undermine treatment recommendations because they weren't aware of the rationale. They also wanted to be familiar with whatever app they're giving to patients. Again, typically folks, reasonably so, want to have a sense of what the thing is before they give it to a patient, before they kind of put their weight behind it. They also wanted to know about the efficacy of different apps. So what is the evidence base behind it, as well as how to select an app from the myriad of sleep apps that really do exist out there. They also said, many of them said they wanted an opportunity to practice these strategies. So that gives us some pieces of thinking about how can we integrate role plays within these didactic workshops. They also wanted access to materials so they could look up how to provide support for specific problems if questions came up along the way as they were doing this in their practice. And they wanted support around addressing different challenges in this integration for special populations. So things that came up are what to do for perhaps with like pregnant or postpartum women, what to do with folks that someone brought up like inpatient settings. Folks also were like, what about adolescents versus adults? So really kind of how to tailor this for different patient groups. And all of this can certainly be integrated into the training. And then our third question was what therapists believe they need in order for this to be feasible. So I split this into first the feasibility of the training. What do they need in terms of actually attending the training? So we intend for this workshop to be a 4-hour didactic workshop with ongoing consultation. And so knowing it's 4 hours, and I want to highlight that this is a 4-hour workshop, and training to competency in therapist-led CBTI is a 3-day full day workshop plus weekly ongoing consultation. So this is much less intense. Again, perhaps therapists who don't have time to do full training in therapist-led CBTI, this is something that might be a bit more accessible just in terms of the busy workload. But therapists identified some, and they were really split. Some wanted let's just do it all in 4 hours. Others were like, can we do it in 2-hour blocks? So what that really tells us is flexible options. And therapists even said, we want some flexibility around scheduling time. Some people really preferred business hours, some want evenings, some want weekends. But most of them said that with advance notice, many things can be an option. So really keeping in mind when scheduling training, having lots of time options available to folks. And they also highlighted really thinking about how much does it cost providers to receive this training? Because a lot of really high quality trainings can also be expensive. And last, we asked about how feasible is it to provide this support in a session, 5 to 10 minutes in a given session to check in on DCBTI use, and also to kind of help problem solve barriers to adherence and engagement. And most providers said this was very reasonable. In fact, they're 10 minutes is reasonable. I don't think clients would be opposed to it. Doing this every session or every other session, totally reasonable. Easy for such an important target. Seems like a reasonable amount of time. So that was their use of words. They kept telling me it was reasonable. In terms of concerns, most of those are really focused on how much time they need to spend looking at data outside of session, thinking about just packed session times, and also billing. So how do I protect time outside of the session in order to monitor their data? If it's a set protocol treatment, it might be really difficult to integrate DCBTI. The person who shared this was someone who does a lot of trauma-focused treatment, specifically cognitive processing therapy, and a lot of CPT sessions can be really packed. So it's also thinking through, is this the right time to do this with a patient? Or maybe that isn't a good fit. And I love this one of the biggest barriers of billing code. What would I do about insurance? Because hopefully the new CMS codes may start to alleviate this concern. And last, just quickly to just show the anonymous survey results. Therapists were somewhat familiar with cognitive behavior therapy on average, the participants. And in terms of this was a fully anonymous survey, so that's really giving them the space to tell us whatever they want. And on average, when asked, what do you think about integrating DCBTI into routine care? They rated it on average as a good to great idea. And in terms of thinking, what do you think about providing support? Again, this was rated on average as good to great, a great idea. So this is really encouraging. The views of integrated DCBTI were generally positive among this somewhat small sample of 52 licensed therapists, and these were therapists we recruited from across the country. A lot of the concerns and their needs can fully be addressed via therapist training, and a lot of these billing concerns hopefully will be alleviated by some of these new proposed CMS codes. And it's giving us a lot of logistics and lessons learned for how to coordinate with therapists around training, how to set that up. But most importantly, it seems feasible among therapists. And it's worth noting that within SHIP, we actually have a training mechanism for training clinicians in therapist-led CBTI. So this is also something that can be integrated into that workshop already. I'm also collecting preliminary data on this for integrating it alongside depression and anxiety. So stay tuned for that in a later, probably next year. So I will stop there. I just want to thank my collaborators and co-authors and of course my funding. And I'm happy to answer questions after our third speaker today.
Great. Thank you so much, Nikki. And you just invited yourself back for a Hubinar in the future. That's what I heard at the end there. So thank you for that awesome talk. And I have scribbled down a ton of questions. So hopefully we'll have time to talk some more. So our third and final presenter is Dr. Michelle Berk, who is an associate professor in the Department of Psychiatry and Behavioral Sciences here at Stanford. She's within the child and adolescent group there. And her research, teaching, and clinical service focuses on psychotherapy approaches for treating suicidal behavior in adolescents with some additional work on suicidal adults. She follows the scientist practitioner model, which I also adhere to, so I like that, in which her research and clinical work reciprocally inform and enhance each other. Dr. Berk will present on the DAISY study of integrating digital CBTI with DBT among adolescents. So take it away, Michelle.
Okay. Okay, so I'm going to talk about a study that Rachel and I are doing, which we are calling the DAISY study, or DBT and Insomnia study for youth. This is a study that's funded by an R34 grant from NIMH, and we're focusing on the integration of digital CBT-I with DBT and looking at the feasibility, acceptability, and safety of that primarily, as well as looking at impact on insomnia and suicide-related outcomes. So Rachel and I are the PIs on this study, and then we're working with some digital CBT-I consultants, mainly Lee Ritterband, who is the developer of Shut-Eye Somrist for adults, and then Emily Law has been working with him on an adolescent version called Firefly, and so we are using Emily's version of Shut-Eye that has been tailored and made developmentally friendly and accessible for adolescents. So the rationale for doing this study is suicide is the second leading cause of death among 10 to 14-year-olds and the third leading cause of death among 15 to 24-year-olds in the United States. So reducing suicide in young people is an urgent public health priority. There's been a lot of research at this point showing that insomnia is a robust and transdiagnostic risk factor for suicidality and suicide deaths in adolescents. However, treating these two things at the same time has never been studied before. No one has studied integrating evidence-based insomnia treatment into evidence-based treatment for suicidality and self-harm in youth, and this seemed like an important next step in suicide research to see if we can improve the efficacy of suicide-focused treatments by reducing insomnia in kids. And our prior work has shown that the vast percentage of kids who are in DBT in a DBT trial that we did, but a huge majority of kids who meet criteria for DBT in terms of high risk of suicide also have comorbid insomnia. I think rates were around 80–85%. So there's a high need for this combination of treatments. Why we chose these particular treatments, DBT right now is the only well-established empirically supported treatment for adolescents at risk for suicide. So it's the only treatment that has been tested in 2 separate RCTs and has showed an impact on reducing suicidal ideation, suicide attempts, and non-suicidal self-injury. So it makes sense to use DBT for that reason, because it's really the only thing with a evidence base right now for adolescents. CBT-I is the gold standard treatment for insomnia in adolescents. And so with my expertise in DBT and Rachel's expertise in CBT-I, we came together to try and do this study, again, which is an initial feasibility and preliminary efficacy trial, looking at the combination of these 2 evidence-based treatments as a novel approach or an extension of current suicide prevention options for youth. And we chose to use a digital CBT-I program, Firefly, because of its scalability, similar to what Nikki just discussed in her talk. It doesn't require a huge amount of time or training on the part of the DBT therapist to be able to integrate it into treatment. And then it increases the likelihood, if it's effective, of more widespread dissemination, because it's very unlikely that there's many providers out there who are trained in DBT as well as CBT-I and know both of those treatments well. So we were looking for an option that would be easy for DBT therapists to incorporate into DBT without a lot of training or expertise in CBT-I. So this is the design of the study. Hopefully this makes sense. So first we're doing an open trial, which is where the part that we're doing right now, which is to pilot test the integration of the digital CBT-I with DBT and try and get a sense of what does the DBT therapist need to do to get the kid to actually do this digital CBT-I program, and sort of what is the optimal amount of support needed from the DBT therapist. And then after that, we're doing a small pilot RCT where kids will get randomized to DBT plus CBT-I or to DBT alone. These are all kids who are brought into the study with inclusion criteria of high suicide risk, meaning a lifetime suicide attempt, current suicidal ideation, history of multiple self-harm episodes, as well as insomnia. Those kids would get randomized to DBT plus CBTI or DBT alone. DBT is a 6-month-long treatment, so they get 24 weeks of DBT. DBT is a treatment program, so it involves individual therapy, a multi-family skills group, access to the therapist for telephone coaching. So they get all of that package for 24 weeks. And then CBTI gets introduced in session 2. So they have one DBT session to start, so the therapist can go over safety planning and deal with safety issues related to suicidality before introducing CBTI. They get access to CBTI in session 2. It's supported by the therapist. Again, we're figuring out exactly how it's supported for 12 weeks. So the first half of DBT, and then they continue to have access to the program for the remaining time they're in DBT, but the therapist is no longer checking in on whether they're using it or offering any help or anything like that. So it's unsupported at that point. I think I probably already went over the aims with my other slides, but we're looking at the feasibility, acceptability, safety. That's the main goal, but also we want to look at whether the digital CBTI is enough to actually reduce insomnia in this patient population, as well as trying to get a preliminary signal within this small pilot RCT. Is this having any differential impact on suicide-related outcomes? So are the kids who are getting the insomnia treatment having decreases in suicidal ideation, suicide attempts, non-suicidal self-injury? And if that's the case, is that mediated by the reduction in insomnia? Okay, so the program we're using is called Firefly. Again, it's an adolescent version of Shut-Eye. It consists of 6 cores or modules, and the 6 cores are listed here. And this is, in my understanding, the standard CBTI intervention, and with these 6 components. The way it's set up is they do 1 core per week. So they have to finish 1 core before it unlocks the next core or lesson the next week. So it's designed to be done 1 per week. Obviously, if they don't finish 1, then they're on hold until they finish it, until they get access to the next one. So they have 11 weeks with support. They have the whole 24 weeks without to get through this, but it's designed to be done ideally in 6 weeks, but we'll see how long it actually takes. The first session is the first core is an introduction to the program, and they need to do, in conjunction with that first core, at least 5 sleep diaries. So the program has them do a daily sleep diary to start core 2, which will go over sleep restriction and give them a sleep window based on the sleep diaries. So that's potentially an area where the therapist needs to give a little more support or a little more push so the teen gets those sleep diaries done so they can move on to sleep restriction and the rest of the active intervention components. This is what it looks like. This is what it looks like when they log in. They get a dashboard with their sleep diaries and what cores they've completed. And then embedded within the program are videos and testimonials and things of teenagers. Again, that is designed to be developmentally appropriate and engaging for teenagers. So there's a lot of stuff on this slide. Again, we're piloting the best way of integrating these 2 treatments, but just some of the things we've been focused on. Again, introducing access to the CBTI in session 2 of DBT, that may make sense. That's something that we're looking at. We had to pick a uniform start time, so we picked session 2, but we definitely need to leave some space at the beginning to make sure that all the safety planning that we usually do in DBT is done first. So making sure the kid has a safety plan, they're not an imminent risk, all that kind of stuff has to happen before we introduce the CBTI component. It's designed for the teen to complete independently, and that would be ideal if they do complete it independently. Probably realistically, they're going to need some encouragement and nudges to do this. So we're also looking at how much of that we need to do. Right now, the therapist is providing at least a brief overview of how Firefly works. They get an email with the login information in their second DBT session. So the therapist is checking to make sure that they've logged on. And that they understand how the program works, making sure they understand the importance of doing the sleep diaries to get benefit from the program. In DBT, there's a big focus on commitment to treatment because we are taking kids who are at high risk of attempting suicide or dying by suicide, and we want them to stop doing that. So we spend a lot of time getting them committed and motivated to give up suicide and self-harm behavior. So we're going to use that same approach to getting them committed to working on their sleep and all these things that you want to be different in your life or goals that you have for yourself. Here's why improving your sleep is going to make it easier to achieve those things. So really focusing on connecting it to things that the teens want and that this is a way to achieve goals they want. We do safety planning with the parent, particularly around the sleep restriction component. So often, even before that, we do it, but often these kids are going to sleep very late because of insomnia, and that they're often online at that time, talking to friends. There's a lot of opportunity for contagion among online interactions during that time of night. It's also a time of night where they're awake, where they would ordinarily be asleep, or usually the rest of the family is asleep. So it's a chunk of unmonitored time, which gives them a window of opportunity to be engaging in self-harm or attempting suicide where nobody is going to intervene or catch them doing that. So we talk with the parent about, you're going to have to stay awake and monitor them until they go to sleep. They may already be going to sleep late. And then once we start sleep restriction, they may be going to sleep even later, but really working with the parent to make sure they're being monitored during that time. We're estimating the therapist will spend about 5 to 10 minutes on Firefly in each session. So as part of DBT, the teen does a daily self-monitoring form called a diary card where they're tracking urges to kill themselves, hurt themselves, other targets. So now we have use of Firefly on there. So the therapist has a quick check at the beginning of the session if the teen has used it, and then gives them an idea whether they want to discuss it or address it in the session. The therapist also has the ability to check the Firefly therapist dashboard to see what their patient has done during the week. So they have information going into the session. Has the kid used it or not? Do they seem stuck somewhere? Have they done sleep diaries? DBT has a treatment hierarchy or an agenda that's standard for each session, where life-threatening behavior is targeted first, therapy interfering second, quality of life third. We're treating insomnia as a quality of life target. So how much time the DBT therapist would spend on it in the context of the DBT approach would be how much time they have left for quality of life targets. So for example, if a teen attempted suicide since the last session, it's likely the whole session is going to be spent on that, and there wouldn't be much time left to do anything related to, have you used Firefly? What would help you use it in that session? But if not, and there's time, there could be more time spent on it. I actually had a patient do one of the modules in the session with me because we had time, and DBT is a very behavioral treatment and dragging out new behaviors. I was like, okay, you haven't done it, we'll just do it now. I didn't help her with it, but I had her do it then while we had a moment. But we're still trying to understand, again, how much involvement is needed, and balancing wanting the teens to do the program with what's feasible in terms of dissemination, and in the real world, in the community with DBT therapists, what's really going to be realistic for them to do, and how can we come up with an approach that is feasible for dissemination. And I think I've covered most of this. I think I'm just going to stop.